Hey y'all, so we have another back patient with back pain lecture today, number 6. One more after this. This one's on vertebral metastasis. You can already see what's going on here. Some lytic lesion in the vertebral body, something in the spinal canal there. But yeah, make sure to subscribe if you haven't yet, and let's get going. So we talked about all the rest of this stuff. Besides this yet, that's our next video posted. Already made the video actually, but this is the last video I'm making on this series right now. But vertebral metastasis. So, cancers that are known to metastasize to the spine are usually breast, lung, prostate, renal cell carcinoma, lymphoma, gastrointestinal cancers, melanoma, pancreatic cancer, thyroid, and others as well. So secondary involvement of vertebrae through hematogenous dissemination, so vascular spread of these cancer cells into the vertebrae. So you have osteoblastic, osteolytic, and mixed lesions. So the osteoblastic are bone forming, like sclerotic extradural lesions, including metastatic cancer of prostate, osteosarcoma, hepatocellular carcinoma, and medullary thyroid cancer. And this is a hepatocellular carcinoma. You can see this vertebral body has, this is a T2 weighted image, and because this is hypointense on T2, meaning it's dark, that means this is a osteoblastic lesion. So this is bone forming, right? This is a bone forming lesion. This one over here is from a renal cell carcinoma, I believe, and you can see these are bright on T2 because the spinal fluid is bright. So we know it's T2. These are bright on T2, but then you have this here. So I'm not sure if this is mixed with some lytic and something else, but bone forming, bone lytic, both. But I don't know. Usually RCC is going to be a lytic lesion. GI cancers, lytic, melanoma, lytic, and multiple myeloma, lytic. Some can be mixed as well, or mostly lytic, but it can be mixed, like breast cancer, lymphoma, and bladder. Urothelial carcinomas. I think that's what they are called. So vertebral metastasis. So if you have a patient over 40 with a spine lesion, got to be thinking, could this be a metastatic lesion? Because primary lesions are less common than metastatic lesions in the vertebra. So you have this patient here. How long have your symptoms been going on for? It can be acute, chronic onset. It can be acute or insidious, slow, progressive onset. I would believe it'd be more insidious and slowly progressive back pain, but I guess it depends what's going on there. Of course, this is just going to progress, right? It's not going to get better on its own, most likely. Characterization. So back pain is going to be dull, usually and constant, can wake the patient up from sleep. Location of pain, it can be localized or diffuse. So it's hard to really, get a nice box of what this looks like. It can be, various presentations. Aggravating factors, usually these are worse at night and no relief with rest. Associated symptoms, fever, weight loss, might have night sweats, lymphoma, multiple myeloma, or other symptoms due to the primary cancer or other sites where there are mets. Typically, there's no neurological deficits, but they may occur due to mass effect if there's some nerve root compression going on. Also, we're talking here vertebral mets, so I'm assuming they can be in the vertebral body. It can be intramedullary, extramedullary, intradural, extradural. So you can have a leptomeningeal. So some of these can cause radicular pain and other things. It depends where it's located, right? And how large it is. Age is a risk factor. Older the age, more risk for cancer, of course. Prior or current cancer, and family history of cancer. And, what's the patient worried about? Always make sure to get their input. Don't let them leave the appointment thinking, what if I still have this? And they aren't checking me for it. And also, have they seen anyone else for these issues yet? So you're going to examine the patient. They might look ill. They might have a fever. You might note when you're inspecting the back a bulge, but you might not. Otherwise, it can just be normal. So when you push on the back, you'll find point tenderness. Range of motion might be decreased. A neurological exam, as we said, can be normal, unless you have some nerve root compression. Spleen or lymph node, or liver, spleen enlargement, lymphadenopathy, skin pallor. So you're looking for, are there any signs of cancer elsewhere in the body? Feel the lymph nodes. Look at the skin. Just feel around. And so here's where these things can spread. Most are in thoracic spines, then lumbar, then cervical. And half of these can be multiple spinal levels. So you can have intradural, intramedullary, extradural. Usually they're extradural, 94%. So the dura, of course, is like that sac inside of here. So extradural can include these vertebral body mets. So yeah, here's extradural. So, you know, the worst one, leptomeningeal 5%. These are pretty bad. People with leptomeningeal metastasis is a pretty grim prognosis usually, and a lot of bad progressive neurological deficits. Oops. Let's see. Is there anything else? We're almost done, y'all. But this is a central canal leptomeninges. So yeah, leptomeningeal metastasis can be pretty bad. You can see here a tumor. This is T1. Is this T1? Well, this is T2 weighted. And this must be T1 non-contrast, T1 post-contrast. So it fills with contrast and enhances. So it's hypo-intense T1, hypo-intense T2. Yeah, not much to see there. Not sure what case this was. But if you have leptomeningeal metastasis, sometimes you'll see enhancement around the dura, dural enhancement, I believe. Leptomeningeal enhancement, actually. But I think the leptomeninges include the dura. Someone can fact check me on that. But yeah, you can have just normal. You can have a tumor extradural outside the dura. You have intradural extramedullary or intramedullary. So, and that's all we got. And that's it, y'all. So the series is complete. I know this is video 6. Video 7 I've already done. So y'all go watch all the videos of the series. I appreciate everyone out there. And keep hanging in there. Don't give up. No quit. We out.